This is Pretty in Practice, the podcast.
Opinions expressed on this podcast are solely those of our own as well as our guests and do not reflect the views and opinions of our respective employers, organizations, academic institutions, committees, other groups, or individuals.
Welcome back to another episode of Pretty in Practice, the podcast. Today we have a special treat for you all. We have our special guest here with us, Ashley Martin, who will be a future Doctor of Audiology. And if you don't know what audiology is, stick around and she's going to break down all the details you need to know about that field. But you can think of things such as hearing and balance, those sort of things will relate to audiology. But I'm not the expert. We're going to have our expert dive in a little bit more. We do have our host, Dee, myself, and Justice here, and Lay is here in spirit, but we are going to continue with the episode and allow Ashley first to introduce herself to you all.
Hey guys, my name is Ashley. I'm super excited to be here. I am a fourth year Doctor of Audiology student, and I am in my residency year, and I go to University of Arkansas for Medical Sciences in Little Rock, Arkansas.
Thank you, Ashley. Welcome to the podcast. So could you dive in a little bit more into your background, your degree, current experiences that you have in the field of audiology?
Sure. So I started this journey at Purdue University with some of you lovely ladies, all of you lovely ladies. And I have a background in speech, language, and hearing science. That's my degree. And then I have minors in linguistics and African-American studies. And all of that kind of came together in this journey of me pursuing audiology. I didn't go straight to graduate school. I took a break. I worked in higher ed for a little bit. I really want to be a Peace Corps volunteer. And I was super passionate about that and went to Peace Corps. And I could not stop thinking about this class I took at Purdue the first time I held my otoscope. And I was like, I really think I want to pursue this when I get back to the States. And when I got back to the States, I found a clinic that was willing to let me be an audiology assistant and fell in love with it and decided to go back to school. And now I'm a fourth year and I love it. I'm super happy with that decision and I'm really excited to start serving the community around me.
Well, we are excited to have you serving the community as well, and we cannot wait to dive in deeper with you. But first, we're going to do our Doctor Diary segment. So today's question, just to get to know us a little bit better, is what is the last show you binged watched? So I'm going to go first, and I've been watching Netflix since my recent move to Fort Lauderdale, and I haven't had anything else to watch but Netflix. And I have been binge watching just Girlfriends. Like, I've been catching up on all of the seasons of the old shows, and that has been my go-to show. So I've been doing that. And then I did start a new show just to bring me to a newer generation, because now I sound host and Girlfriends. But I did start a new show called Designing Miami, which is about interior design. That's also on Netflix too, which is really awesome if you're into interior design. Check that out. What else have you guys been watching?
I personally, I restarted watching Snowfall. Just rewatching it from the beginning. Yeah.
I've never watched Snowfall.
Snowfall is super good. You definitely need to watch it.
It's really good.
I'm gonna do what you did, India, and I'm gonna talk about two shows that I've been binge watching. On Disney Plus, I rewatched That's So Raven. Just because I'm like, when school started, I needed something to like boost my mood at night, like before I go to bed. So I started watching That's So Raven, and she is still hilarious like years later. Like, I'm watching it and I'm cracking up. And I'm on like the fourth season. I think she only did 4 seasons. So I'm gonna have to find something else to make me laugh. And then I actually finished watching a show on Netflix called Never Have I Ever. It's about an Indian American teenager. That's also kind of like a comedy. It's just about her like navigating life and balancing between her two cultures in high school, which is very entertaining.
Oh, I love that. Okay, special guest, what are you watching?
I'm watching so much, but I started watching Sister Sister again because I just needed some little good throwback show, and it's really funny. And Keenan and Kel, people slept on Keenan and Kel. Keenan and Kel is hilarious.
Okay.
I have been watching Keenan and Kel, and it is so funny. Even as an adult, it's probably funnier than when I was a kid. Really, it's good. They were ahead of their time.
Every time.
So underappreciated.
Yes, I definitely agree. So now that we wrapped up our doctor's diary, we're going to get right into the questions. So the first question that we have for you, Ashley, is what led to your decision of selecting audiology as a career path? I know you kind of mentioned that you worked as an audiology assistant and that you were kind of like fixated on a class that you took at Purdue, but can you talk a little bit more about how that decision came about?
Yeah, I mean, I'm super passionate about improving people's quality of life. That is my whole little mantra for why I do everything I do. And when I did Peace Corps, I loved helping people, but I'm a person who really likes autonomy. I like to be the boss. And I really wanted every day to wake up and be excited to go to work. And I wanted to feel like I was making a difference. And so I was trying to think of careers that would give me all those things. And I just kept going back to that class. And if I'm being really candid, I had never really thought about pursuing the field because you do have to get your doctorate. And I was like, oh, I'm not trying to go back to school. That's a lot of work. I had already got a big girl job and was making money. And I really didn't want to take a step back. But it just kept calling on me. And I was looking for something where I could have more purpose in life. And so I just took the plunge. And I'm super happy because I get to see patients every day and help them and help make their life better, help them hear their grandchildren, help them hear loved ones. And it's really awesome. Not to mention we do balance as well. And we can talk about that a little later, but the hearing portion is very rewarding.
That's really amazing. It sounds like you made the right decision despite having to go back, for 4+ years. It sounds like you're going to have an amazing career that you enjoy. So definitely excited for you. You kind of started mentioning it as well. So we'll just talk about that now. Can you explain to our audience what an audiologist does and where in the healthcare field we may see you all? Because even myself, as a medical student, I am completely new to this field. So please, please, please let our audience know what you do.
I think a lot of people don't really know about our field. My research project that I did during school was about not access to audiology, but knowledge of audiology. I want to see how many people actually knew what it was. And in my research, I found that it was typically people who were low SES who didn't know what it was. Patients who come from affluent backgrounds, they know because, for generations, their family has been getting hearing aids because they could afford them. But it's not typically something that's on our radar. Well, I shouldn't say our, but in lower SES communities' radar. But I'm sorry, I done got backtracked off the question. I'm so sorry.
Oh, no, you're okay.
What was the other half of that? You were asking.
Yeah, so we just kind of want to know,
what we do, of course. Yep. I'm so sorry.
No, you're fine.
So we specialize in hearing and balance. Okay, so we diagnose and treat hearing and balance disorders, basically anything to do with the cochlea. If we're talking about the middle ear and structures of the middle ear, you're thinking of an ear, nose, and throat, an otolaryngologist specialist. If we're talking about cochlea, if we're talking about permanent hearing loss, any balance disorder, if someone has vertigo, anything like that, you're going to come see me or someone like me.
And Ashley, you mentioned SES. Can you define that just in case?
Sorry.
No problems at all.
So SES, being low socioeconomic status. That was my research. It was comparing high socioeconomic status, so basically people who have money versus people who have less money, to see how many of them had knowledge about the field of audiology, even knew what it was, what they did, and went from there.
Perfect. Thank you. And in terms of the populations you traditionally work with, do you work with those of lower SES status, or what is the traditional population that you are used to working with in your field?
So unfortunately, at least I'm in Georgia right now. I'm in a clinic in Georgia doing my residency year. There is not a lot of insurance coverage for hearing aids here. You can get your hearing tested and get it covered, but there's not a lot of coverage if you need hearing aids. And hearing aids can be upwards of $5,000 or $6,000 easily for the set, and you need to get them every 5 years or so. It's really expensive. And the majority of my patients are private pay. These are patients that can just write that check the same day of the appointment. Okay. So of course that's going to make a class difference. I'm also in a private practice, which makes a difference. There are nonprofit hospitals here in Georgia, and I would really like to see how they navigate that, because insurance doesn't cover hearing aids. So I'm not really sure how they're able to fit patients with devices that are appropriate for their loss and still be able to sustain themselves as a practice. But yeah, unfortunately, a lot of my patients are higher income.
That's so unfortunate. I cannot even imagine that financial burden, already going through the difficulties of dealing with hearing loss of some sort and then having that financial burden. That's just absolutely unbearable. But in terms of, and I'm sorry, were there more you wanted to add there?
Well, I was just going to say, in other states, like when I was in Arkansas, that was rarely a problem, because the insurance plans that were there, a lot of them did have a hearing aid benefit. And I think there's not a lot of knowledge about it. So I think with more information will come more access.
Absolutely.
That's what I believe. It starts with education and getting the word out. And when there's more of a demand for it, I think the insurance companies will feel pressure to provide that in their benefits package.
Well, we are so fortunate to have you here, getting the word out, spreading the education, especially to our community. And we keep mentioning hearing aid, and I know some people might associate hearing aid with just the elderly population, those older. What does your population look like? Do you have people who come in who are younger? I know myself personally, I dealt with hearing issues as a child, and still deal with hearing issues to this day. Haven't been formally diagnosed or anything like that, but that just gave me a first glance that people who are younger can have some type of hearing loss. But I would love to hear on your end, what type of population do you work with in terms of age range?
I see babies, like newborns, all the way to my oldest patient that I see in this clinic is 102.
Oh, wow.
So I mean the gamut. I mean, hearing loss, a lot of it is genetic. Sometimes it's congenital. It happens. It's a structure within the body that can be afflicted just like any other structure. And yes, the more birthdays we have, the more likely it is that we're going to develop hearing loss. But patients are across the gamut or across the age range.
Awesome. And are there any signs and symptoms that people can look for in terms of hearing loss, specifically to kind of determine if this is something that could be impacting them?
Absolutely. So I think people think when they lose their hearing, everything's just going to get quiet one day, or everything is just going to be hard to hear. That's not how it works at all. With hearing loss, red flags to look for is ringing in the ears. If you're noticing ringing in your ears, you might want to get your hearing checked. If you notice that you can hear people, but you can't always make out what they're saying, and you feel like everybody's mumbling and it's hard to understand them, you might want to get your hearing checked. If your friends or family is saying, you know what, I feel like I have to keep repeating myself. You keep asking me to repeat myself. Like, you should probably get your hearing checked. It might be time to get your hearing checked.
Please, everybody take these.
Up to that. But who do you go to first? So is this something you go to your primary care physician to first, and then they refer you out to an audiologist? Like, who do you go to first when you notice those things?
Here is the problem, right? A lot even in our field, yes, I'm sure, we do get a lot of referrals from practices, but a lot of times I'll have patients say, well, my physician said not to worry about it. They said, we're having this conversation fine. You're probably fine. A lot of times they don't get referred. And it's the patients who, know somebody who knows something about it who ends up coming to see me, or they have someone who refers them. But a lot of times people will go to their physician first and say, hey, I've noticed a change in my hearing. And then they'll say, well, we'll wait till it gets a little worse. And the problem with hearing is there's a phenomenon called auditory deprivation. And the longer you leave hearing loss untreated, after a while, your brain does not process the signal the same. Which is really problematic, because if we can find hearing loss early enough, we can get you a hearing aid and we can basically keep your loss steady for more or less, and it doesn't decline more. I mean, yes, you may get a little bit of reduction as we age, but for the most part, it'll stay steady. If we leave it untreated, it drops faster, and we may lose the ability to process the sound, even if it is loud enough. And you don't even have to be in that situation if you would have just known, right? Like, information and knowledge is the barrier between somebody being able to continue to have meaningful communication and not.
True. So you mentioned coming to see you. So as a physical therapist, we have different laws on different states on when they can just walk in to see a physical therapist versus when they need a referral from a physician. Are people able to walk in and see an audiologist, or do they need a referral?
For the most part, they can walk in unless it's something, if we're experiencing something that may point to something bigger, like pediatrics. Pediatrics, we try not to see pediatrics without a referral. Also, if someone has like a whopping asymmetry, again, sometimes it depends. If we discover it first, then we're going to refer them to a physician because we need to rule out any other interference before they can be fit with a hearing aid. But for the most part, you can just come and see us. You typically don't need a referral in most cases.
Okay. And then before you had kind of mentioned the difference between an ENT and an audiologist and when you would see them, I just wanted you to kind of double back on that, because that's something we also had a question about. So if you could just dig a little bit more into that, that would be great.
A lot of times, so ENTs and audiologists work very closely together. Those are typically going to be the physicians that refer you to us, more than likely. So it's like we all have our lanes, right? Their lane is like the middle ear. Anything that to do with like the anatomical structure of the ear, if your ossicles or the bones in your ear, if they're not working, that's going to be an ENT. Or if you have a bunch of fluid behind your ear, pediatrics who have a lot of ear infections, that's going to be at your nose and throat. A pediatric that was born without hearing, that's going to be me, because it's anything at the level of the cochlea or the inner ear is typically audiology. Anything at the middle ear is going to be an ENT. That's typically a good rule of thumb. That's very elementary. The way I just put that, it's a little more complicated than that, but yeah.
Just for our listeners, because I totally understand middle ear and inner ear and all that good jazz. Is there a more simple term, like a simple way to explain the difference between like your inner ear versus your middle ear? Because both of those are still inside your ear, but like,
fair enough.
I guess
fair enough. And I keep forgetting that I need to like not. If you have a permanent hearing loss, okay, let me say it like this. If it can't be treated with surgery or medication, you come see me. If it can be treated with surgery or medication, it's going to be an otolaryngologist or an ENT.
Okay. And D, you had a question? Or did I?
That was my question. The ENT versus the audiologist. That was my main question.
Okay.
It's confusing.
We kind of touched on it. What was that, India?
I was just going to ask one more question. I know we were talking about hearing a lot, but we did also touch on balance and other conditions too. Do you have other areas that you focus on as an audiologist as well?
Absolutely. So the clinic I'm at, it specializes in hearing and balance. It's called the Hearing and Balance Clinic. Literally, that's the name. And we have 3 locations. But we do, if people are experiencing vertigo or other things like dizziness or unsteadiness, we do a bunch of tests that basically provoke the system. We have a chair that literally spins. We have a screen that makes their eyes go back and forth, or, we basically create nystagmus, so that to try and figure out where the issue is, what is making them dizzy. And then we work together with ENTs and neurologists to diagnose and treat that patient. And that is really cool, but it's hard because sometimes you really have to make the patient uncomfortable in order to figure out what's going on with them. You literally are making them dizzy on purpose. And sometimes it sounds funny, but sometimes it's tough because it can get emotional. The patient is sometimes really miserable in those situations. And if you're somebody who really wants to help somebody, you feel really guilty, but it's a necessary evil in order to getting them the help they need. So
that's so interesting.
So when we tested for vertigo in school and stuff, they mentioned like people would sometimes also throw up. Is that something you've seen with that? Like you get them dizzy, or their vertigo comes on and it just kind of makes them throw up?
We always have the stuff. We always have the stuff. Like the bags, the ice packs, the Gatorade, the water. But and let me knock on some wood right now, but I haven't made anyone throw up, but that's because I ask a lot of questions during testing. I'm like, are you good? Do you need a minute? You want some water? Do you need some air? Like, I'm very engaged with the patient during testing because it's a long test. It takes about 90 minutes of us just doing different tasks to provoke their vestibular system, which is another part of the inner ear, the part that helps with balance. But it's tough, but I try to be very compassionate and talk them through the whole thing. And I, knock on wood, 4 years, I haven't had anyone throw up on me yet. But I have been in the other room when somebody was throwing up in the other, like it wasn't my day to be in the vestibular part of the clinic, and people do throw up. It happens. Absolutely.
And then I just got another follow-up question to that, because we spoke on nystagmus, which I just want to note is an involuntary rapid eye movement. And then we also talked about vertigo. So that's a term that people also may not know. So could you describe that, like what exactly someone might be experiencing when we say vertigo?
Yeah, sorry. So when people experience vertigo, or what we like to classify as vertigo, sometimes people will say, oh, I have vertigo, but it's not really vertigo. But a lot of times when we're talking about vertigo, I'm talking about the sensation that the room is spinning around you, and you're not doing anything to make it spin. It's just happening. A lot of times you don't have sense of your body or where it is in space or how to stabilize or balance yourself. It's a really uncomfortable sensation. Sounds like, I've never experienced it, but it sounds tough.
Yeah, so I just want to note to our listeners that when she says the inner ear, that's a very big portion of our bodies knowing where we are in space and if we're accelerating up or down, left or right. So when those are thrown off, obviously we have those wild sensations, and our body doesn't know what to do with it because it's used to the body working on a certain plane and direction.
Yeah. I have a question. It's kind of general. You can talk about as many or as little as you like, but like, what are some of the treatment options that you all do? So, for example, like whether it's an ear problem, whether that's like a hearing aid, or like what would you all do for vertigo? Do you all prescribe? Like, I'm just curious to know, like, okay, you diagnose the problem and then what? Like, what is usually the next step for like someone with hearing loss or someone with vertigo or nystagmus?
So our the whole way we do it is figure out where the problem is and then go from there, right? So if they have hearing loss, for example, I had a patient today, they had hearing loss. It was a conductive hearing loss, meaning there was nothing wrong with their cochlea or the permanent structure. It was something in their middle ear. They had an issue with their ossicles, right? The bones in your middle ear. I referred them to an ENT to get that managed. However, even with me referring them to the ENT, I knew they were going to find their way back to an audiologist because I knew that we had already done surgery on that ear and there was a very low likelihood that we were going to do another surgery. So the next step for that person is something called a BAHA, which is a bone anchored hearing aid, which is fit by an audiologist. However, we have to rule out if there's anything we can do medically to manage that problem before we give them back to another audiologist. So even though I know they're going to end up back to somebody like me, then, that's what we do. Another patient I had, I did their hearing test. All the tests lined up. They had a sensory neural hearing loss or a hearing loss at the level of the auditory nerve or the cochlea. There's damage either at the nerve or the cochlea. Either way, that's our playing field, right? So I could just go straight into recommending hearing aids for that person and explaining how the hearing aids are going to essentially retrain their brain to get used to hearing sounds that they weren't hearing before and having access to those sounds again. If a patient has a vestibular disorder, right, it might be peripheral, meaning it's at the cochlea where the semicircular canals are, or we're in the inner ear, okay? Or it might be central, so somewhere in the brain, right? If it is something peripheral, there are certain maneuvers, and Justice can tell you, they do them too in physical therapy, that can help get the crystals back in place, right? If it's central, I'm going to refer them to a neurologist. So that's kind of how we do that. That was a very long explanation, but
No, that's super cool. I'm going into primary care, and it kind of sounds like y'all are like the primary care for like the ear. I don't know if that's the like correct way to say it, but it's like you all can figure out what's wrong, manage it if you can, and then if you can't or need approval for anything, then you send them either to like neurology or ENT. That makes a lot more sense to me now.
As a pharmacist, I have a question. We're talking about treatment, and there are a number of options you just listed that you can treat, and I'd imagine there's some medical things that can help, but also there are medical treatments that can cause vertigo and dizziness.
Absolutely.
Or things like blood pressure causing orthostatic hypotension. So how does that impact your field of study?
Yes. So anytime we have a vestibular patient, or somebody who has an issue with balance, let me say it like that, someone who comes in because they're dizzy, that's how I'll say it. The first thing we do is we make them fill out a detailed case history because 80% of that diagnosis is going to come from that. And one of the biggest things we do is we ask for their medication list. And we try to check their drug interactions and see if any of their drug interactions are going to cause any dizziness or vertigo, because that might be the issue right there. We might find it before we even have to do any like vestibular rehab. Sorry, that's another treatment we do. We put the patients through exercises that help them deal with their symptoms and makes it more manageable and tolerable. That's another thing we do.
So I love that call out to know that there are a number of different factors that can cause vertigo, dizziness, and some other things. So you really do have to do a thorough workup and a diagnostic just to figure out what's going on with the patient.
Before they even walk through the door, we have, of course, the first discovery appointment, but before the second appointment where we can start doing the diagnostic test, we have to do a thorough case history and figure out what else might be going on.
I love that. And I love the crossover of all of our fields into these conditions, even things I never thought about audiology before today. I mean, we don't touch that in pharmacy, but I just see so many crossovers that I never got to have a lens to before. So this is really great.
And you might know about ototoxic drugs, right? Some drugs can cause hearing loss. If we take, matter of fact, chemotherapy and radiation, a lot of my patients, especially a lot of my pediatric patients who, you know, unfortunately have some form of childhood cancer, we start doing super high frequency testing on them at a young age just to monitor their hearing, because we know they're at higher risk for losing their hearing because of the chemotherapy drugs. But of course, if you have to pick one, you're gonna save the child's life, right? But it is something we monitor and try to mitigate before it becomes a larger issue. But
absolutely, and I said this once and I'll say it again, but this is why you need so many other providers in the room at the table, because when we all come together as an interdisciplinary team, we just are able to optimize the health in such a better way than just solo provider.
This is so true. Just to take us out of here, I want Ashley, if you can give us and our listeners one piece of advice about our health from an audiologist or a Doctor of Audiology student, we would love to hear it.
I feel like this is general, but I always tell everybody, now that I'm on the other side of things and I, you know, just see a lot, ask questions. Do not assume that because your healthcare provider did not mention it, that everything is okay and is fine. I think sometimes people say, oh, well, they didn't ask me about that. It must not be a big deal. Ask questions. If you're worried about something going on in your body, if someone didn't explain something to you in a way that you can understand, ask follow-up questions. If you're not buying their answer, ask some more questions. It is okay. It is your healthcare. It's your copay. It's your money. You should be getting your money's worth. Ask questions. And make sure you understand everything and that you're getting the best healthcare that you deserve, especially in our community.
Yes, we love to push the advocacy piece. We do, because it truly means a lot. Like it's one thing to be on the other side and to know like that people are lacking just questions, but yeah, like please ask questions. Like healthcare providers have a lot of patients, like they just have a lot going on. So like to put it on them to be the one to worry about your health is not good. It's not going to do you any good to leave your health in their hands. Like, yes, you should be able to like respect and expect your healthcare provider to do the best for you, but like they got a lot going on. Like, you know you better than you. So yes, please advocate for yourself. But yes, we want to say a big thank you to Ashley. This was a really great episode. It also showed us how important the team is. As you can see, some of these patients could be from physical therapy. We do the similar treatments versus on the medication side, the pharmacist versus seeing your primary care physician who might send you there. So this is just a big reminder that this is a care team, and then one person can't do it alone, no matter that person in healthcare. So yes, thank you again, Ashley, and we're going to remind you all to keep it pretty. Thanks for joining us.
Thanks, y'all.
As always, thank you for joining us for the ride. Be sure to keep in touch by following us on Instagram and subscribing to our YouTube channel at Pretty in Practice. Feel free to send us a DM of any topics you want us to discuss, and you might hear them on a future Pretty in Practice episode. Keep it pretty.